All right, so welcome back. This is part 6 in our articulations lecture. In this part, we're going to look at some joints that have to do with our upper limb, including our shoulder joint, and some joints associated with our uh, scapula, as well as our sternum and clavicle. Right. So the first joint we'll look at is our glenohumeral joint. So just as we mentioned in the previous part, the names of these joints are typically going to involve the bones or the regions of a bone involved. So in this case, gleno refers to the glenoid cavity of the humerus, and then of the scapula, and then the humeral refers to the humerus itself, right? So this is the joint between the scapula and the humerus, and this is, of course, our shoulder joint, right? Our actual shoulder joint. So this is a diarthrotic joint, right? So meaning it is freely movable. We can move it with a great range of motion. So we have flexion, extension, abduction, adduction. We have rotation. So we have circumduction. So we have 3 degrees of freedom, 3 axes of rotation, right? So as we mentioned in previous parts of this lecture, because it's very mobile, that inherently means that it is going to be less stable, right? So it is a frequently dislocated joint. And recall in previous parts we talked about the difference between a shoulder dislocation and a shoulder separation. So in this case, this is the glenohumeral joint. So this is an actual shoulder dislocation if you disarticulate these bones here, right? So this is multi-axial. We've got flexion, extension, abduction, adduction, circumduction, rotation. This is a ball and socket joint. So remember, a ball and socket joint is a subtype of synovial joint, okay? So the ball in this case is going to be the humeral head, or the head of the humerus, right? So if we see humerus here, this is the head of that, okay? And then we have the socket part, or the more depressed part, which is the glenoid cavity or the glenoid fossa, okay? And so this is a relatively shallow socket. It's a relatively shallow joint. And so because of this shallow nature of the joint, that also lends it to being a little bit less stable and more prone to dislocation, right? So in the glenoid cavity, in the glenoid fossa, you have an accessory structure, right? And this accessory structure is known as a labrum, right? And we'll see the same thing when we get down to the hip joint. But a labrum is something that deepens the concavity of a joint, right? Or deepens the concavity of a socket in a ball and socket joint, right? So in this case, we're talking about the glenohumeral joint. The socket, as we said, is the glenoid cavity or glenoid fossa. This ring of cartilage that you see around here, this fibrocartilaginous ring that runs around the glenoid on the kind of perimeter of the glenoid fossa, this is a labrum, right? This is specifically the glenoid labrum because it's associated with the glenoid cavity, right? And so what this does is this starts to deepen the socket that the head of the humerus then articulates with, right? So if you think of like a small tea plate or a small dinner plate, something like that. It's very flat, okay? If you were to put a ball on that plate and rotate the plate slightly from side to side, that ball is probably going to roll right off, all right? Now, if you take that same plate and you put a lip on it, you put a lip going around the side of it, then you now decrease the chance of that ball rolling off the plate and you keep it in the plate itself, right? So you keep it in the socket. That's what a labrum is doing, okay? So it's deepening the concavity and it's helping to keep the head of the humerus in this case, and when we get down to the femur, it helps keep the head of the femur in contact with, in that case, the acetabulum, right? So it is a protective structure that helps keep it in place. So if we look at the shoulder joint a bit more closely, we see that it is largely supported by muscles, okay, and it's stabilized by muscles. So this group of muscles that we've alluded to previously is known as the rotator cuff, right, or the rotator cuff group of muscles. And this is a group of 4 muscles that we'll look at in later lectures and later in lab. So these are named according to their position on the scapula. All right, so if you recall the scapula or shoulder blade, you had a spine of the scapula, and then you had different areas around the spine and different areas on the anterior and posterior sides of the scapula. So above the spine, you had a region called the supraspinous fossa. Below the spine, you had a region called the infraspinous fossa. So the muscles that sit here are known as the supraspinatus and the infraspinatus, right? Pretty relatively straightforward naming scheme. On the underside of the scapula, so what we see here, this is the subscapular fossa. So you have the subscapularis, and then you have this one small muscle known as the teres minor that attaches over to the greater tubercle of the humerus, right? So all of these are serving to both stabilize the shoulder, keep it in place, but also help with movement of the shoulder as well. So whenever you raise your arm up and you move it sideways and you move it down and you rotate it and whatnot, this is largely being accomplished by the action of these rotator cuff muscles, okay? So if we look at a closely related joint, but a separate joint nonetheless, this is our acromioclavicular joint. So instead of being a joint between the scapula and the humerus, now we're looking at a joint between the scapula and the clavicle, right? And we've talked about this previously before, okay? So this is the acromion process of the scapula. So this is where we get the term acromio. And then this is the clavicle here. So this is clavicular, right? So in this example here, this is an example of a shoulder separation, right? So this clavicle, the acromial end of the clavicle, has become disarticulated from the acromion process of the scapula, right? So you have this AC ligament, you have this acromioclavicular ligament that joins these two bones. Maybe there was some type of trauma, some type of force, he fell on the arm, something like that, that caused this AC joint to become separated, and so you call this a shoulder separation, right? This is a gliding joint, very little movement that occurs here. So it is a synovial joint, but it would be more considered an amphiarthrotic joint as opposed to a diarthrotic joint. Okay, so this is our AC joint. If we look similarly, so instead of looking on the acromial end of the clavicle, now we look on the sternal end, we see the sternoclavicular joint, right? And so the sternoclavicular joint is the joint between the sternum and the clavicle. And so here we see the outline of the sternum here. Here we see one clavicle on the right. Here we see one on the left. This one on the right, you see here's the border of the sternum, and here's the sternal end of the clavicle, and there's this nice separation between the two. And so that's what you were seeing here on this left image. This is a sternoclavicular dislocation, all right? This is an extremely strong joint, okay? It is a synovial joint. It's a gliding joint. Very little movement, but it's extremely strong. And so you're more likely, sometimes more likely to break the clavicle than you are to actually dislocate it at this joint. But in this case, you see it dislocated, and you see it kind of projecting anteriorly through the skin. So this would be what's referred to as an anterior sternoclavicular dislocation, in which the sternal end of the clavicle projects anteriorly and protrudes into the skin here. All right, this is sometimes better than a posterior dislocation, because just posterior to the sternum and posterior to the clavicle here, you have several very important blood vessels and nerves that if this clavicle were to go posteriorly, you would run the risk of potentially damaging and potentially puncturing one of those vessels, all right? So the last joint that we'll look at associated with the shoulder is known as the scapulothoracic joint, right? So this isn't a joint like some of our other joints that we look at. This is a interesting joint because there's not actually a joint cavity, there's no synovial cavity, but it's more connected just via musculature, all right? And so this is a joint in which the anterior surface of the scapula, so that we see right here, so this anterior surface of the scapula, joins and articulates, you know, kind of quote unquote articulates with the posterior and lateral aspect of our thoracic cavity, right? And it slides and glides anteriorly on that thoracic cavity via the action of various muscles. And one of the most important muscles is known as the serratus anterior, right? So we'll look at the serratus anterior later in future lectures and in lab, but this is a muscle that causes protraction of the scapula, okay? It causes it to move anteriorly as if you were throwing a punch forward and you throw your arm forward, you bring your scapula forward with it as well, right? You also have some muscles associated with the neck and associated with the back that move this scapula along the thoracic cavity, the rib cage here. So muscles like our rhomboids can do this. They attach to the lower cervical and upper thoracic vertebrae as well as the medial border of the scapula, and this can cause retraction of the scapula, in which you're pinching your shoulder blades together, right? So if you extend your shoulder blades back and you try to bring your shoulders together on the posterior surface, this is the adduction or the retraction of the scapula, and that's being accomplished by some of those rhomboid muscles that we'll look at in later lectures, right? So we will stop here with this part, and we'll pick up by talking about the by talking about the elbow joint, and then we will move on to then discussing some joints of the lower limb.